So Sweta, can we start? We are live now.
Are you able to see my screen, Saurav?
No.
No?
No.
Now?
Yes.
Yeah. Hello, everyone. Welcome to this webinar on International Mucopolysaccharidosis Awareness Day on this 15th day of May 2022. I am Shweta Das. I completed my fellowship in clinical genetics from Christian Medical College, Vellore in July 2021. I also recently completed a fellowship in prenatal genetics from University of Barcelona, Spain in March 2022. And currently I have joined as an assistant professor in JVA University based in New York in the Aruba campus as an assistant professor in biochemistry and medical genetics. So this is our agenda for today. And I welcome Mr. Saurav Singh, who is the founder and chairperson of Rare Disease India Foundation, to give us the welcome speech. He is an MBA from Symbiosis Pune, and he has worked for 14 years in various multinational companies across India. He has been actively campaigning for creating awareness in rare diseases from over 8 years and has persistently advocated for development of effective national rare disease policy in India. He has been awarded with National Cadet Corps A certificate, B certificate, and C certificates, and has been honored to participate and meet the former Prime Minister of India, late Atal Bihari Vajpayee, in Republic Day camp in the year of 2000, and also has been awarded by the Governor of Bihar in 2000. His efforts in the field of rare disease patient advocacy has been recognized several times in various platforms. I welcome you, Mr. Saurav Singh, to give your welcome speech to our audience. Thank you.
Hello, everyone. I am Saurav Singh, co-founder and chairman of Rare Diseases India Foundation. This is my honor to welcome all of you on behalf of Rare Diseases India Foundation for this International MPS Awareness Day, 15th May 2022. Every year we celebrate this day as MPS Awareness Day globally. First of all, I would like to thank Sanofi to support us for this International Awareness Day 2022. And I also thank to Centogene to come forward and support us. Thank you, ECMERI, for becoming our strategic partner. And last but not the least, I wholeheartedly thank to National MPS Society USA for associating us with a mission to create awareness around the world. First of all, I would like to inform you that Rare Disease India Foundation is a patient advocacy group. It is established in 2019. This is a non-profit organization which works for rare disease awareness in the country. There are around 7,000 to 8,000 rare disorders, and mostly it is genetic. Only 6% to 8% of population in India affected with rare diseases, and 72 to 96 million people suffering from rare diseases. Why awareness is important? If we know about these diseases in advance, we can certainly control and manage these diseases somehow. Genetic counseling, if the suspected couple goes to the medical genetic counselor on time, there are chances to get some remedies. If the disease can be identified early, the medicine may be started early. Lack of awareness, including medical fraternity. It is the major obstacle on the way of rare diseases. There are lack of awareness about rare diseases, including medical fraternity, patients, general public. Patients have to visit hospital to hospital for correct diagnosis in India. There are also many challenges in rare diseases in the country. Either there is no treatment available or the treatment is unaffordable by an individual. Early diagnosis of these diseases is also one of the major challenges because the symptoms generally appears after 2 to 3 years of age. Life expectancy in this disease are very less. Still, we are struggling for a proper rare disease policy in the country. The cost of the medicines comes in crores, which is unaffordable by an individual. No insurance company covers these diseases. Rare Disease India Foundation appeals everyone to let's join our hands together to spread awareness around the world for rare diseases. So today we are going to discuss in these issues. We have the expert doctors from India and abroad. We also have MPS patient, caregiver, leaders, and patient advocacy groups from different countries. I welcome our keynote speaker, Professor Mamta Muranjan from KEM Hospital, Mumbai, India. She has a very vast experience in medical genetics. I also welcome our special guest, Tracy Kirby, who is the Director of Development, National MPS Society, USA. National MPS Society has done amazing works in advocating MPS diseases. Another speaker is Dr. Veronica Aurora. She is Associate Consultant, Medical Genetics in Sir Gangaram Hospital, New Delhi, India. I welcome Mr. Akash Prasad, who is the young boy suffering from MPS I disease. He will tell his own journey. I welcome Miss Ingrid. She is from Estonia. She is the mother of MPS III kid, Rahel. She will share her journey also. And last but not the least, young and energetic moderator for this session is Dr. Shweta Das. She is Assistant Professor, Department of Biochemistry and Medical Genetics from Xavier University School of Medicine, New York, USA, Aruba campus. So over to you, Dr. Shweta.
Thank you, Saurav. I'll share my screen again. I would like to introduce our special guest, Tracy Kirby, who is the Director of Development of the National MPS Society, USA. In this role, she is responsible for building and maintaining relationships with families, donors, pharmaceutical companies, biotech companies, and other stakeholders in the MPS community. She has been working to raise funds for research, advocacy, support for families is in her job currently. She is very passionate about doing her job, and Tracy has over 9 years of experience working with lysosomal storage disorders, and she has also been the Director of Family Services in the Patent Disease Support and Research Association. With regards to her education, she has completed a degree in sociology from the Ohio State University and forensic accounting from the Franklin University. Over to you, Tracy. I welcome you to deliver your talk on global challenges of MPS across the world.
Thank you very much for that welcome. I'm going to share my screen now. And thank you for welcoming me and asking me to be a participant in this. I think it's very important, as we all know internationally, that we work together and work better together. I do currently work at the MPS Society, which is based in North Carolina in the United States. It was founded in 1974, and we support all MPS and ML syndromes. And as I just mentioned, we work with various international sister organizations. Our mission statement is very simple and very powerful: to cure, support, and advocate for MPS and ML. The ways that we do that to cure MPS and ML is we support research through fellowships, grants, and various projects in different parts of the country. To date, we have funded over $11 million in research. We work with other lysosomal storage disease organizations and patient support groups throughout the world. Supporting families, we have a monthly newsletter. We put on an annual conference. We have a Pathways program, which supports families through their first year of diagnosis. And we offer grants to families in a variety of different ways. Some of them are helping them obtain durable medical equipment and continuing educational opportunities. For advocacy, we sponsor many public events throughout the year. We issue press releases. We publish syndrome-specific and treatment materials. And we have a very active and updated website, which we include updates on various research, legislative activities, family support, and upcoming events. Global challenges, I think no matter where we are in the world, we recognize that we face some of the same challenges. It's getting an accurate diagnosis in a timely manner, having access to treatments that are meaningful, as well as access to necessary medical professionals and necessary equipment. As Saurabh was saying, diagnosis is one of our major issues. Usual time to receive a correct diagnosis can be anywhere up to 6 years, with many inaccurate diagnoses happening in the meantime. As he also mentioned, that the time frame to treat is between 2 and 3 years. Many of the treatments prefer that they treat the child before their first year of birth or no more than 18 months old. The best way to get a diagnosis is obviously screening at birth. Here in the United States, we have a newborn screening, which we do have 2 forms of MPS on. There is an international screening group as well. It's hard to get on newborn screening, as we all know. And part of the issue also is that we cannot rely on clinical diagnostics. Many times you have a child, you take them to the doctor because as a parent, you see some issues happening, and the doctor will refer you to a specialist for that specific symptom. And then something else happens and you see another specialist. All of this adds up to the long time to receive the correct diagnosis. And what is happening is they are not treating the disease as a whole, they're treating each individual symptom. Various treatments are out there, as I know our other speakers will speak about today. There is the ERT, which is both intrathecal and interventricular and IV. We have the HSCT, and we have various gene therapies. Right now, there are many companies working in gene therapy. We are hoping that the clinical trials go well and we can come to a situation where the drug is then offered to the public. Access to professionals and equipment obviously depends on a diagnosis. Once you get that diagnosis, then you can often get access to the equipment, but we know that throughout the world, this is not the same for everybody. Having the best equipment and the best professionals leads to a quality of life that we want for everybody. And having the right information also lets the families make the correct decisions they need to make for the child or the adult with MPS and ML. Chasing the Signs is the theme of International MPS Awareness Day. And very simply, what we do is we always ask families to share what signs they saw that led them to a diagnosis. And if you share on social media, the hope is that it will help bring attention and awareness of the diseases to other families who can then go to their doctors with this information to maybe speed along some sort of diagnosis or treatment. And it eliminates delays to the treatment that we know is so vital. Thank you for, I said, inviting me. Here's our contact information if you'd like to reach out or have any questions. And now I'll pass that back to Shweta.
Thank you. Thank you for that wonderful talk, Tracy. Now I invite Dr. Veronica Aurora for our next lecture on the biochemistry of mucopolysaccharidosis. Dr. Veronica Aurora has done her MBBS, MD, and DNB super specialty in medical genetics, and she has also been a gold medalist in the field of medical genetics during her residency. She is currently working as a consultant and an assistant professor in Sir Gangaram Hospital, New Delhi, and is an executive member in the Delhi chapter of Society of Fetal Medicine. She is the course coordinator and faculty in the Genetic Counseling course in Future Academy India and has published more than 55 papers in peer-reviewed journals in medical genetics. She has special interest in metabolic disorders, fetal malformations, autism, recurrent pregnancy losses, skeletal dysplasia. She has to her credit, phenotyping of novel gene, GFRA1 for renal agenesis, and she has to her credit various awards and multiple publications. Welcome, Dr. Veronica Aurora. Over to you.
Thank you, dear Shweta. I really thank you for this kind introduction, and it's a pleasure meeting you. Also, my real earnest thanks to Mr. Saurabh and Tracy for their selfless work in the field of rare diseases, especially MPS. It is very rare that we see people working so diligently for disorders, and we are just helping you guys reach there. And it's a big, great effort that all of you are putting. Thank you, Mamta ma'am, and for joining this. You being here has really made the standard of this program very high. And everyone else, I hope I have not missed anyone. And Akash and everyone who's present here. It's with you guys' morale that we are able to put these programs together and just be so confident in treating the disorders. So I'd be really looking forward to hearing about journeys of all the MPS families that are present here. And with that, I'll just start my talk. Just let me know if my screen is visible, Dr. Shweta.
Yes, your screen is visible, Dr. Veronica.
Thank you. So I'd been given the task of speaking about the biochemistry in mucopolysaccharidosis. It's a very interesting set of disorder with the biochemistry, which is changing, the different set of imaging, the different set of diagnostic techniques that we now have, from the enzymatic to the dried blood spot and the molecular testing techniques. I would be sticking to the biochemical nature of these disorders. So today is the MPS Awareness Day, and the need for testing is because the incidence of this disorder is 1 in 25,000, and that if diagnosed early, if treated early, the children do really well, as we have so many examples. So the great societies like Rare Disease India Foundation and National MPS Society of USA do help us reaching that goal of treatment, along with the various other parental societies that are present and which might go unnoticed, and of course our lovely children and adults of MPS. So starting with the basic unit, the lysosome. So lysosomes are I'm just trying to keep it simple for the parents and the children. So they are really little cells, organs that help in digestion of the enzymes. Like we have digestion of the food, and the food that is undigested needs to be thrown out. They're surrounded by a membrane composed of phospholipids that separate the inside of the lysosome from the membrane's external environment. There is a little membrane separating the lysosomes from the external environment, and they have this particular size. They're like a floating bag of garbage that contains enzymes that are capable of digesting these particular molecules called GAGs, which are not good for us, which are not good for our body. And the accumulation of these molecules called GAGs is the basic pathophysiology behind mucopolysaccharidosis. So the garbage bags that are the lysosomes, they really dispose of all the gags and the other material that is not required by the cell and is a result of the metabolic processes that occur inside the cell. They're responsible for recycling or excretion of the disposals. So there are many sort of lysosomal storage disorder, enzyme defects in any part of the lysosomal and the metabolic processes inside the rhizosome can lead to lysosomal storage disorder. There are approximately 49 kinds of them, but the MPS constitutes approximately 30 to 40% of all of the lysosomal storage disorders. So the initial description of MPS was done by Charles Hunter as back as far as 1917. The case was described, these patients were described actually in two brothers who were aged 10 and 8 years. We know that MPS type 2, that is Hunter syndrome, is the only type of MPS which is restricted to males, that is, has an X-linked recessive inheritance. So these brothers had hearing loss, dwarfism, macrocephaly, cardiomegaly, umbilical hernia, joint contraction, and skeletal dysplasia. And as we all know, once a person sees MPS, again, he will not miss this disorder. It has such a specific gestalt to it. Obviously, I'm talking about the more severe variety. So they were discovered as back as in 1917. And also they had a little girl who was the sister and who was normal, showing more of a predilection for boys. I'm not sure if they knew the inheritance that time. So MPS2 was actually the first MPS that was discovered, and not long after was their discovery of Hurler, Morcu, Sanfilippo, Mortulemi, Sly, Shi, and Natowitz. So by 1996, we did have discovery of all the different kinds of MPSs, and here we see all the stalwarts who were involved in the same. So as I was talking, this picture just highlights how lysosomes are just so important for the disposal of the degraded products. If we have a normal degradation, there is a recycling and everything moves perfectly. But if there is a missing enzyme, there is unfortunate accumulation of all the glycosaminoglycans or all the unnecessary products of metabolism, which causes deposition of these products in different parts of the body, causing the typical storage that we call the lysosome storage disorders. So dysfunction of at least one of the lysosomal enzymes causes these accumulation in different organs, and of course there is a multi-organ involvement. They are hereditary, they are progressive disorders which are caused by mutations or variants in the genes that code for these lysosomal enzymes. So most of these disorders would result in a progressive phenotype. So what really happens when this whole cycle occurs? There is an enzyme deficiency which causes lysosomal storage of substrates and an impairment of autophagy. Autophagy is programmed cell death, so the cells do not die on their own. They have these toxic proteins that cause cellular distress, phagocytosis by microglia, and a process of chronic inflammation. This chronic inflammation causes cytokine release, and then there is more cell death, increasing the accumulation of more toxic metabolites and distress to the existing normal cells. So MPS group is a constellation of several genetic diseases due to deficiency in any one of the 11 enzymes that contribute to the degradation of GAGs. So when the GAGs get accumulated because they are not being able to get degraded by the enzymes, there's activation of the toll-like receptor 4 pathway. So I will just cut the long story short, and all these different metabolites present here are pro-inflammatory metabolites. So for the geneticists in the forum, there is an increase in the transcription of pro-inflammatory regulators like the tumor necrosis factor, interleukin-1, metalloproteinases, prostanoids, and all this leads to a degradation of the extracellular matrix, cartilage, bone, joints, etc. There is enhanced proliferation of the abnormal products, and there is increased apoptosis of the normal cells. So as we said, there are 11 known enzyme deficiencies, which leads to increased storage of GAGs. And there are 7 main types of mucopolysaccharidosis. And the type 1 is known as Hurlers, She and She, Hurler being the most severe. Type 2 is known as Hunter syndrome. Type 2 is the only X-linked MPS, all others being autosomal recessively inherited. Type 3 is only mostly restricted to the central nervous system, presents with ID, autism, speech delay, and it is called the Sanfilippo types. And this is one type where we are soon going to get a gene therapy for, and a lack of enzyme replacement for this as well. Then we have MPS type 4, more of a skeletal MPS, and 6 in which we could have a preserved intellect. Type 7 could be more severe, and type 9, a rarer MPS due to high urinase accumulation. So about the clinical features, Mamta ma'am will be discussing in detail as well. So about the biomarkers, the biochemical markers of mucopolysaccharidosis. So what are really biomarkers? They are analytes that can be measured and used to indicate a pathological or a physiological process. Thus, they allow discrimination within the disease versus non-pathological events. So these are indirect markers of the disease activity as well as the diagnostic processes that we can use for. If well chosen, a biochemical marker or a biomarker can be helpful for diagnosis, prognosis, and they might also be able to help us in monitoring the therapeutic efficacy, for example, in MPS after enzyme replacement therapy. So, sorry, just one second. So as we see here, a long chain composed of carbohydrate, a GAG structure, could be uronic acids, amino sugars, or neutral sugars that are the glycose portion of the glycosaminoglycans. The glycosaminoglycans are large complex carbohydrates that interact with a wide range of proteins. They can be present in the extracellular matrix, they can be present in the bones, cartilage, CNS, in a lot of places. The function of the GAGs is they are negatively charges of the GAGs attracts cations like sodium, and they suck in water and create a pressure and enable the extracellular matrix to withstand the compressive forces. They are ideal as lubricating in the joints, provide structural integrity to the cells, and are attached to proteins, making them the proteoglycans. So basically, they maintain integrity of all the extracellular matrices they are present in. So as MPSs are primarily associated with GAG storage, they are the natural biomarkers that are present for these disorders. There are different types of GAGs depending upon the molecules that is attached to them. And the different types of GAGs do help us in differentiating in the different types of MPSs. The different types of GAGs include the keratin sulfate, which is more of a skeletal GAG, the chondroitin and the dermatin sulfate, and the heparin sulfate, which is more of a CNS associated GAG. So depending upon the type of GAG that accumulates in a patient with MPS, we can get a clinical idea which process or which MPS enzyme deficiency we are dealing with. For example, this table here shows that, and as we can see here, the chondroitin sulfate localizes to the cartilages, tendons, ligaments, and aorta. It is a sulfated protein. The dermatin sulfate again to the skin, blood vessels, and heart vessels. The keratin sulfate mostly to the cartilage and cornea. That's why we know in MPS 4 there is involvement of the bones, of the joints, and the cornea is also involved very frequently. The heparin sulfate mostly to the basement membrane and the cell surfaces. So the skeleton seems to be a little spared in these disorders. So when we talk about urinary GAGs, the easiest sample to obtain from an MPS patient is urinary GAGs. The analysis with dimethylene blue, the DMP, or the electrophoresis have been the most used biomarkers for MPS. This marker has also been used with reliable results as a surrogate markers in clinical trials with enzyme replacement therapy. A careful evaluation should be performed of the long-term measurements of GAG due to influence of the age, anthropometric variables, renal functions, phenotypes, and potential causes for the false negative results. Keratin sulfate also sometimes is used as a marker for skeletal dysplasia. So my point here really being that a lab needs to be well validated and well standardized to be able to be performing these GAG electrophoresis on the urine, to be differentiating the qualitative GAG analysis in the different types of GAGs and giving an idea of the clinical phenotype. Historically, the berry spot test was also used based on the metachromatic staining of the urinary acid, MPS. So that was initially used. Now we have the more easily available tests like enzymatic assays. The first step in the diagnostic process, of course, includes your GAG analysis. If your GAG is increased, then you go and do the enzymatic assays. Leukocytes, cultural fibroblasts, or fibroblasts are generally used. Also, we can use dried blood spots here. Also, we have some indirect markers beside the use of direct markers by GAGs. The indirect markers I don't think are very easily available everywhere, and especially in the low resource settings as in some parts of our country. So there are fibroblast growth factor type 2 is a molecule with high affinity for HS, thus it can be used for HS detection. The heparin cofactor through thrombin complex is also affected by GAG metabolism, so that it can also be used. So now coming on to fibroblasts, do we use fibroblasts for GAG analysis? So the answer is in India, we do tend to use leukocytes more if the urine is not available. Fibroblasts offer the advantage of minimizing the variation effects in temperature and shipping due to cell culture in the lab. The use of fibroblasts also means a larger amount of sample in which a larger number of cells can be cultured. The disadvantages are related to the invasive collection in the skin, which is the biggest disadvantage. The leukocytes are more preferred. The procedure of fibroblasts is more expensive as well. Leukocytes from whole blood are an alternative to the enzyme assay without the need for cell culture. So in most of our clinical setting, a leukocyte enzyme-based assay is preferred. This is very useful, for example, in the postnatal investigation of family with a history of MPS 1. In most cases, leukocyte samples provide enough cell counts for the analysis, or if cells are not enough, a new sample collection may be possible because it is just a blood collection. The only challenge here sometimes remains that if we are getting a sample from a distant place, the samples are susceptible to temperature variations, which is a big issue in tropical countries like ourselves. To avoid the sample deterioration, it is recommended that samples must arrive in the laboratory maximum up to 48 hours post-draw. The plasma samples may be useful for the assay of some enzymes associated with 1, 2, 3b, and 7 when leukocytes cannot be obtained. In this case, plasma could be obtained and stored frozen until shipment is possible. Generally, leukocytes are preferable as a more reliable source for enzymes. So now coming to the dried blood spot, the most popular and the young artist in the queue. It's very interesting alternative mainly for several regions where the shipment of blood to skin biopsy is a challenge. However, as described for leukocytes, proper sample collection, correct collection of the DBS sample is very important for the correct interpretation. So the DBS card is in everything in newborn screening should be collected properly, all the circle filled well, and it should be done by an expert in DBS analysis. So there is no doubt about the power of the use of DBS and enzyme assays for screening. Nonetheless, this sample is still not considered a gold standard, such as fibroblasts or leukocytes, because there is a smaller number of cells per spot. Thus, positive results in the DBS screening should be confirmed in leukocytes or fibroblasts. This is one point I would like the house to also comment upon. Do you confirm a DBS sample based enzyme on leukocyte assay as well, or are we considering it as a gold standard? Then to assure the quality of enzymatic assays, it is important to always include a positive and negative controls to analyze in additional enzymes. There is also a possibility of multiple sulfase deficiency, which we should always remember, in which the reference enzyme should be a sulfatases, and if we have a deficiency of 2 or more than 2 sulfatases, we should think about the MSD phenotype. With regards to mucolipidosis type 2, type 3, lysosomal enzymes are not target to specific cell types and excreted in cellular matrices. So for mucopolysaccharidosis type 2 or ICEL disease, we will have an increased elevated amount of sulfatases or the lysosomal enzyme in the plasma and the deficiency inside the leukocytes. So this is something which is new as well. Now we have digital microfluidics, which can help in the enzyme detections as well. And this is something we look forward to in the future. So finally, I would also like to point and talk about the pseudo deficiency. Generally, a deficient activity of one of the lysosomal enzymes involved in the GAG degradation is associated with MPS. However, there are individuals who showed greatly reduced enzymatic activity but remain clinically healthy. This condition, termed as enzyme pseudodeficiency, is due to the polymorphic genetic variations and can affect some of the lysosomal hydrolases. The potential presence of an enzyme pseudo deficiency poses a limitation for enzymatic tests and should be investigated whenever results of an enzyme do not concur with the phenotype. Just something that we should remember and not perform prenatal diagnosis for such families. So whenever there is a clinical suspicion of MPS, we do a GAG, a quantitation and a qualitative analysis in urine. If it is increased, we can do a specific enzyme assay and a specific molecular diagnosis. We can also do a blood-based WBC, plasma DBS directly, and finally a molecular diagnosis. This is the protocol that tends to be followed. And again, this just shows another school of thought which says that you can do a very spot test first, followed by a qualitative and quantitative analysis of GAGs. But I think we in India, if Mamta ma'am would agree, we follow directly doing a GAG followed by enzyme and molecular analysis. So finally, I would like to end my talk. I'm sorry if I did take too much time, and thank you so much for your patient listening. And the disease may be rare, but the hope should not be. Thank you so much for listening.
Thank you so much, Veronica, for this wonderful, elaborate and simplified talk. I now
So if
welcome,
ma'am would like to comment on, ma'am, we are doing the GAGs directly, right, ma'am, without the berry spot test, or do you do it differently?
Yes, I absolutely agree with you, Veronica. Our practice is doing the quantitative and the electrophoresis, confirmation by enzyme, and then molecular study.
Thank you.
I would now like to invite Dr. Mamta and Muranjan ma'am, who does not need an introduction actually. She is a professor of genetics division and Department of Pediatrics in St. GS Medical College and KEM Hospital, Mumbai. She is also the consultant clinical geneticist in PD Hinduja National Hospital and SRCC Children's Hospital, Mumbai. She has an experience of 27 years in clinical genetics. She has been the member of editorial board in various journals and has held various executive positions and has been the member of various rare disease societies. She has been a speaker and a panelist at various international and national workshops and has 6 chapters to her credit and several other publications. She has been awarded for her excellent presentations a number of times. And few of her research highlights includes being a principal investigator at the Indian Council of Medical Research as a task force on inborn errors of metabolic diseases. She has worked on newborn screening for congenital hypothyroidism and congenital adrenal hyperplasia, a multicentric study. She has also conducted a phase 3 randomized, multicenter, multinational, double-blinded study to evaluate the efficacy, safety, and pharmacokinetics of once daily versus twice daily dosing of ZENS 112638 in patients with Gaucher's disease type 1 who have demonstrated clinical stability on a twice daily dose. She has to her credit various other research work. I welcome you, ma'am, to give the talk on treatment and management of mucopolysaccharidosis.
Thank you, Shweta, for that kind introduction. And just give me a moment to share my slides.
Yes.
Shweta, are my slides visible?
Yes, you are visible and you're audible, ma'am.
Thank you. And good evening, Saurabh, Veronica, and my friends and colleagues in India who have tuned into today's program. And good morning, Tracy and Shweta. And Ingrid, it is my pleasure. And thank you, Saurabh, for inviting me to be a part of today's MPS Awareness Day. So I have been asked to speak about the management and treatment of mucopolysaccharidosis, but I'm also going to touch upon some of the challenges that we have faced at KEM Hospital in the diagnostic journey and treatment of mucopolysaccharidosis. So I bring greetings from KEM Hospital, Mumbai. KEM Hospital, Mumbai is now one of the 8 centers of excellence nominated by the government of India for rare diseases. So at my center, mucopolysaccharidosis is the most frequent amongst the lysosomal storage disorders. And as Veronica also commented, about 35% of our LSDs is mucopolysaccharidosis as a group. Amongst the mucopolysaccharidosis in our part of the country, the most frequent is MPS type 4. And at my center, all MPS type 4 have been 4A. To date, in almost 25 years of my practice, I've not had a diagnosis of a MPS 4B. The second most frequent MPS is MPS 3 and 2. And I believe the landscape of a distribution of mucopolysaccharidosis is more or less very similar in centers, at least in the southern part of India. I think in the northern part, maybe Veronica would comment on it. MPS 1, MPS 2, and MPS 3, 4 are more common. Now, coming to recognition of MPS, one of the most obvious features ought to be the coarse facial appearance. By coarse faces, I mean these individuals have large heads, they have large fleshy noses, thick eyebrows, long eyelashes, the cornea may be cloudy, and even the lips are thick and fleshy. And overall, the face has a very large, loss of delicacy in features, and the tongue is always prominent with macroglossia. So a coarse facies is just one part of the manifestation. Mucopolysaccharidosis is a multi-system disorder, and apart from the coarse facial features, these individuals also present with varying degrees of hearing loss. They have chronic symptoms of upper respiratory tract, colds, ear discharge, ear infections, breathing problems. Very often the heart is involved, causing insufficiency or leaky heart valves. The abdomen is enlarged because of distension of the liver and spleen. In the early years, in the first few years after birth, many of these children have umbilical and inguinal hernias. And often we have seen that many of these patients, before coming to us at a genetic center, have undergone surgeries for a repair of hernias, or even surgeries, ENT surgeries for placement of tympanostomy tube. Many of them have undergone adenoid and tonsil removal even before a diagnosis of mucopolysaccharidosis is suspected or confirmed. Additionally, some patients also have diarrhea as a symptom, and the hallmark of mucopolysaccharidosis is poor growth. So their stature is short. They have a typical joint stiffness involving the large as well as the small joints, and involvement of the fingers leads to the typical claw deformity. And some individuals who have CNS involvement have intellectual disability and seizures sometimes in MPS type 2. And a very typical finding, which we see almost exclusively in Hunter syndrome or MPS type 2, are these pebbly, pearly papules over the trunk, particularly inferior to the scapulae. And if you look at babies or even people who have MPS type 2, they have a lot of facial and body hair. So this is a phenotype which makes mucopolysaccharidosis recognizable, as the manifestations are quite overt. And now Veronica has talked about the various subtypes. So there are 11 different subtypes of mucopolysaccharidosis resulting from 7 enzyme deficiencies. However, just by looking at the clinical phenotype, one may be able to discriminate at least some of the major subtypes. So here I have shown an individual who has very obvious coarse facial features, a large tongue, macrocrotia. This girl at 8 years was very short. The abdomen is distended. There is an umbilical hernia. I hope you can appreciate some stiff fingers with clawing. So this type of phenotype would be seen in Hurler syndrome, that is MPS type 1H, in Hurler-She, that is MPS type 1HS, and in people who have MPS type 2, those would be boys, since this is Hunter syndrome is X-linked recessive, and MPS type 6. So with this kind of a typical phenotype, one would think of MPS 1, 6, 7 also, and Hunter syndrome if this is a boy. On the other hand, people who have Sanfilippo syndrome of MPS type 3 may not have the overt coarse facial features that you see in the other MPS types, which I have just described. Similarly, the joint and bone involvement is much milder. Short stature also may not be that obvious. And as you can see, this girl here, she's about 6 or 7 years old. You can recognize the coarsening of facial features. However, looking at the trunk and the limbs, they have very mild joint stiffness, if at all, and certainly not the obvious abdominal distension, hernias, and large joint involvement that you see in the other MPS types. On the other hand, in MPS type 4 or Mortual syndrome, the phenotype is very different. Veronica mentioned earlier that this is the type where the predominant involvement is skeleton, joints, and ligaments. So these children can be extremely short. They have these breastbone, which is protruding out. They have a bump on their spines, which is a gibbous or a kyphotic deformity, a short neck, corneal clouding, which can be appreciated here. And in addition to that, these are children who, as opposed to the typical MPS, having joint stiffness, people who have Morquio syndrome have joint laxity. So this is very roughly how one could clinically discriminate between the various MPS subtypes. And again, in each individual type of MPS, there is a spectrum, with those at one end having very mild or an attenuated phenotype, and on the other end of the spectrum are individuals with very severe involvement and attenuated lifespan. So just again to give an example, in MPS 1, the She variant is the mildest one, with the mildest symptoms recognized late in adolescent or even in the adult age group. Hurler-She is an intermediate phenotype, and Hurler is at the most severe end of the spectrum, where these children have symptoms as babies in the first few 6 months to 1 year of life, and they have very severe manifestations and a shortened lifespan. They may not survive beyond the early teen age group. Now, even the radiology in the various MPS subtypes can sometimes help in clinically suspecting a condition. In MPS 1, 6, 7, and 2, if you look at the spine here, they have anterior beaking, and the changes are most obvious in the lumbar spine. And you can appreciate that these lumbar vertebrae are abnormal, they are ovoid, and there is this beaking, which is more prominent in L3, 4, 5, giving rise to a gibbous spine deformity. On the other hand, in MPS type 3, the skeletal changes are milder and may be difficult to appreciate by people who are not familiar with the diagnosis of MPS. And the bone abnormalities, especially the spine abnormalities, is very classical and overtly different from the other MPS types. And you can see here, these are the bones, the spinal vertebrae, are flat, so they have flatty spondyli. So apart from that, the other features of MPS are dysostosis multiplex. So all the bones, in general, the skeleton is involved in all types of MPS. Now, having described some of the typical phenotype and the X-ray changes, I'm going to talk about why MPS is a challenge for diagnosis. And here I would like to present some of the analysis that we did of our data. And Tracy did mention that it's a long diagnostic journey of up to 6 years. So at our center too, what we found was that from onset of symptoms to the diagnosis, the delay could range from something like 4 months to 84 months. And we've had patients coming to us as young adults in their 20s who just had hearing loss. The family was not really concerned about the short stature, joint stiffness, or even the cause facial features. So there is a lot of delay in diagnosis. They go to many specialists. And Tracy also mentioned that the symptoms are treated. So an ENT person would treat ear involvement, operate for adenoid tonsil hypertrophy. They would go possibly to a rheumatologist for joint stiffness. Many of my referrals, especially MPS type 4, have visited the orthopedic surgeon, suspected to have rickets, and have received massive doses of vitamin D before it was realized that this is not usual rickets, since these patients obviously do not respond to vitamin D. And that is when they have been referred to a genetic service for the diagnosis. So we've seen a delay of almost 4 months to 84 months. However, once these patients come to a genetic service, the time to diagnosis can be as less as 3 months to 37 months also. And this time lag from presentation to a genetic clinic to diagnosis of almost 2 to 3 years is because many of the families have to arrange for finances to undergo a diagnostic test, which can be quite expensive in some low-income situations in India. And another reason why the diagnosis of MPS is delayed is because of the very non-specific early signs and symptoms. So in the first 2 years of life, most of these patients have symptoms of otitis media, they have hernias, they have recurrent colds, nasal blocks, and it is only as a child grows up that other features become obvious. So all mucopolysaccharidosis, like all other lysosomal storage disorders, is a progressive disease. And as the glycosaminoglycans start accumulating, the features over the years become more and more obvious. So somewhere by 3 or 4 years, these children are then maybe noticed to have coarse facial features. Then the abdominal distension becomes evident, and the joint abnormalities, stiffness, which is a hallmark, which could be a hallmark of MPS, again develops in the by 4 to 5 years of age. And at our center too, we tried to look at what are the barriers to early diagnosis or correct diagnosis of MPS, and the results were not very surprising. There were physician-related factors, and the most common was that the physicians simply overlooked the symptoms. Many of our patients had an alternative diagnosis before coming to the genetic center, and sometimes the physicians erroneously reassured the family when the family expressed concerns about poor growth. Many of them were initially diagnosed, as I said, like rickets or even hypothyroidism, and then referred. The caregivers too had contributed to the delay. Even though they were referred to a genetic service, the caregivers did not come for many months or years. Most of them reported a resource crunch. They could not get the finances to reach a Mumbai city or even have inadequate resources to undergo the battery of tests that Veronica has listed in her presentation. The parents too overlook symptoms, especially in the early stage. A child with recurrent coughs and colds may be just diagnosed to have an allergy, and some of them failed to visit the referral center despite a timely referral by the referring physician. So to summarize, the most common factors in about 50% of our cohort of patients were a physician overlooking the symptoms, alternative diagnosis before the correct diagnosis was suspected, late consultation by the caregiver, and resource crunches. And sometimes, especially in uh, individuals with mild symptoms or attenuated phenotypes, the diagnosis was obviously late because the onset of symptoms was late. Now, once MPS is suspected at our center, a practice is to obtain a quantitative urinary gag excretion, electrophoresis, and I do find this very useful because when there is a situation of a resource crunch, one would like to look at the electrophoresis, the pattern of gags which are excreted, and then decide zero down upon the likely enzyme to be tested. And enzyme testing is quite expensive. In some of the commercial labs, it could vary from 2,500 to 5,000 per enzyme. So when the resources are to be used carefully, one would like to have an electrophoresis to decide which enzyme I would like to test. Now, once we have a positive screening, the next step is an enzyme activity. And Veronica already said that a leukocyte sample is one of the most common samples that is used. And now we do have facilities and easy availability of dried blood spots. And in a country like India, it is very convenient to obtain a dried blood spot sample and mail it or courier it to different parts of the country, even from remote villages and other relatively inaccessible areas. And we always encourage a molecular testing. Sometimes it is helpful to get a molecular testing to predict the phenotype from the genotype. If, for example, in people with MPS 2 who have large deletions of the gene or significant deletions of several exons, they could have a severe phenotype. Molecular testing is the only means for carrier detection, especially in Hunter syndrome MPS 2, to detect female carriers, and prenatal diagnosis by far molecular testing would be most reliable. Some may ask about the role of X-rays. I personally do not ask for a skeletal survey for suspecting or diagnosis of mucopolysaccharidosis because there are other efficient testing methods which are accessible and available. And one would not like to take so many multiple X-rays and subject the child to radiations. Now, once a diagnosis of MPS, any subcategory has been confirmed, at our center, we do a thorough systemic evaluation to look at the burden in different organs. So one would have a complete standard ophthalmological evaluation. This would include a fundus examination, intraocular pressure, and a slit lamp to detect corneal clouding, a complete neurological examination, and as indicated, an MRI or CT of the brain to look for presence of hydrocephalus, MRI and X-ray of the cervical spine to look for spinal cord compression as a result of atlantoaxial instability, neurobehavioral testing, and bilateral median nerve electrophysiology to detect carpal tunnel syndrome. In addition to that, in children who are older than 7 or 8 years of age and who are able to cooperate, we would want a pulmonary function test and a sleep study. In those children whom we are contemplating treating, we have an objective assessment of joint range of motion and an MRI of the or ultrasound to get a liver and spleen volume, ear examination and ENT consultation, and last but not the least, cardiac evaluation with a 2D echocardiography, color Doppler, ECG, and in some cases where there is a significant cardiomyopathy, a Holter monitoring for arrhythmias. In addition to that, we've already, if not done earlier, urinary gag excretion is also advised, especially when we are starting treatment for a baseline quantification. Now, the questions which every family is going to ask, in fact, they ask you right at the first consultation, is there a treatment for my child? So fortunately today, there are several products used to treat MPS with enzyme replacement therapy. And the treatable MPS subtypes today are MPS 1, HS, and 1S. We do not treat MPS 1H or Hurler syndrome with enzyme replacement therapy. The treatment of choice would be hematopoietic stem cell transplants. In Hurler syndrome, ERT would be given only as a bridge therapy to improve the condition or to condition the child for before a hematopoietic stem cell transplant. Apart from MPS 1, MPS 2, MPS 4A, 6, and 7 are the other subtypes for which enzyme replacement therapy is available. And for Sanfilippo syndrome, there are several products which are at various stages of development or of clinical trials with intrathecal or intraventricular enzyme replacement therapy. And in countries where there is lack of access to ERT, there have been some patients who have undergone hematopoietic stem cell transplants. And we do expect gene therapy for some of these MPSs in the near future. Now, I just wanted to illustrate our experience with one of our patients with MPS type 2 who started receiving Elaprase at 5.5 years of age. And from this sorry for this very complicated table, today he has completed almost 7 years of enzyme replacement therapy. And what you notice from this table is that there are some features of MPS which are maybe completely reversed by enzyme replacement therapy, but there are some features which, though they improve, they are not completely reversed. So for example, in our child here, there was some improvement in the coarse facial features, though that did not disappear. The child had a very good increment in the height as well as the weight, which was obvious within the first 1.5 years of treatment itself. The growth velocity improved. There is a resolution of hepatosplenomegaly, and in our patient, the enlarged liver and spleen completely regressed to normal volume. The joint contractures, there was some improvement, particularly in the first 2 or 3 years after therapy. But after the third and the fourth year, the joint range of motion stabilizes but does not normalize. This child, despite being on ERT, did have progressive genu valgus, which required surgery at 8.5 years of age. Apart from surgery for genu valgus, he also had to undergo bilateral carpal tunnel release and a tonsil adenoid removal with a myringotomy and Grommet placement. One of the other parameters which we measure and monitor to look at the improvement in endurance is the 6-minute walk test, which has shown improvement. And despite ERT, this boy is showing early signs of cardiac valvular involvement beginning between 9 to 10 years of age. And he continues to have a hearing loss. Initially, it was conductive because of frequent ear infections, but now he has also started having a sensory neural component. And as you can see, monitoring the urinary gags is very helpful in those on treatment. Veronica mentioned this is a good and easily obtainable biomarker. And from 168 at baseline, at 3.5 years of age, he is now almost having a near normal excretion of urinary gas. So this is just to show you that with ERT, there is a substantial resolution of some features in MPS, and improvement in others, and some like the cardiac and the hearing and some other hernias and skeletal changes may progress, may not get improved, and may require surgical corrections. And again, it is important that it is the age at which treatment is initiated, which is going to also determine how well these people are going to respond. So anybody who is on treatment, they require periodic surveillance. And when before we start treatment, we do counsel the family that enzyme replacement therapy is not going to be curative of it is altering the natural course of the disease, reversing some manifestations, not all. And despite ERT, these people are going to require surveillance of growth, neurological involvement. I would here also like to mention that in those subtypes of individuals with MPS who have a neurocognitive involvement is not going to be affected by ERT, as enzyme replacement therapy does not cross the blood-brain barrier. So again, this is another point to talk to the parents about their expectations, what can improve, what can completely resolve, and what is not expected to be affected by therapy. So we monitor urine gags, like I showed you in our patient, some imaging to document a resolution of the liver and spleen volumes, 6-minute walk test, 3-minute stair climb test, a pulmonary function test to monitor the percentage predicted for forced vital capacity, joint range of motion, a left ventricular mass index, obstructive sleep apnea, hand function scores, and every time they come to us, most of the infusions are given weekly, except in MPS type 7, which is every other week. We also inquire about infusion reactions, any other adverse events. And though this facility is not available in India, ideally one would like to monitor ERT antibodies. Now, having described our experience with ERT, some of the challenges we are facing, and Mr. Saurabh Singh already has alluded to the lack of accessibility of treatment in India, and many of our families with LSDs and MPS have been compelled to resort to litigation in order to fund therapy. So none of the therapy is covered by health insurance. A lot of supportive care that is required for these families is all out-of-pocket expenses, in addition to the expenses for traveling to an infusion site. And there is a loss of school days, loss of working days, and some things that we encountered in our patients who were receiving ERT commercially. So we have a tax on all products that are sold in India. So the GST at the rate of 12% was charged on all commercially supplied products. So those of patients who are receiving enzyme replacement therapy as a charitable gesture are not charged GST. So one of my patients who was getting the ERT reimbursed by the employer had to pay all Indian rupees 28 lakhs per year, which the company was deducting from her salary. And ultimately, after a big, long struggle, finally the employer stopped deducting this GST. And well, we do have a light at the end of the tunnel. There is a national rare disease policy. And through this policy, it is envisioned that the patients would receive therapy through crowdfunding. There is a digital portal that has been created, and all the 8 centers of excellence in India have access to this digital portal to upload the patient's data. And we are looking forward to receiving funds from public sector enterprises and other corporates by voluntary donation for funding the treatment. So what we are hoping for, and this is what awareness programs should be focusing on, is to meet some of these gaps and reverse the challenges. The most from a physician perspective, awareness among the physician community, not just restricting to the pediatricians, but the orthopedics, ENT surgeons, maybe endocrinologists also, for picking up early signs, encouraging and proactively, I would say, encouraging these families to visit a center of excellence or a genetic center for diagnosis and management, being able to recognize the spectrum variants and early recognition of attenuated phenotypes. Again, once you diagnose somebody as having mucopolysaccharidosis, the journey doesn't end there. Whether they are receiving some form of therapy or not, all these individuals require periodic monitoring to early to detect complications early and treat these complications. There are certain avenues for enzyme replacement therapy, even in India, and so these families need to be directed to such centers where enzyme replacement therapy can be given. And there has to be a multidisciplinary team which includes all the various specialities which have the expertise to take care of the surgical burden in these patients. And finally, the focus, at least in India, would be the correct and early diagnosis with genetic counseling and encouraging families to undergo prenatal diagnosis. And all this has to go hand in hand of creating awareness in the community amongst the patients and the families to not ignore symptoms, to not wait for the child to outgrow symptoms. And this is where advocacy groups like the LSDSS and the Rare Disease India Foundation would play a role by acting as a liaison between the families, between the physician community and the families, and most important, government. So with that, Shweta, would there be time to watch a short video?
Sure, ma'am. I think Saurabh, we can adjust, right?
So, Mr. Saurabh, is there time to watch this video? Thank you so much. So this video was prepared by one of my patients' parents, and they were very generous enough to put together this video, which to be uploaded on the national digital portal. And this is encouragement of what all, how ERT has transformed people's lives, those who are living with MPS. Thank you very much for your attention.
Thank you, ma'am, for the wonderful descriptive talk. It was really nice listening to you after long. Now I invite Mr. Saurav again to share a journey as a father to a MPS 2 child.
Once again, hello, all of you. Apart from all this, I'm also a father of MPS 2 kid Shaurya. Shaurya is born in 2011 and now he's 10 years old. He born very normal and there was no problem before 4 years of his age. Slowly, his head became enlarged. We visited all the pediatricians, neurologists, and all the related tests were already done by the doctors. But no doctors identified that my son is suffering from this kind of disease. So I was working with a leading multinational bank at that point of time. I booked an appointment in the top hospitals of India. And there I found that he's suffering from MPS 2.
My talk, just a few. Can I give a phone? Give. I'll come and sit here.
Yeah. So in CMC Vellore, my son was diagnosed that my son is suffering from MPS 2 Hunter syndrome. And at that point of time, there was no drug. And I was surprised that how a disease can be deadly for a child. I returned back to my house and thought that if there is no treatment available, there is no drug for my kid, so how I will go ahead? After some time, Shire Pharmaceuticals, there is a drug company who started some charitable access program for the drug Elapras. But my son was not selected in the first round of that because I applied late. After some time, the drug became commercial and the price was very high. No individual could afford that price because the price was in crores. So I approached the government and I visited so many doctors and the hospitals. Doctors and the hospital said that there is no such policy for rare disease patients and the government cannot expend such amount for a single child. So I started writing letters to many of the all the concerns. I written a letter to Prime Minister, President, Health Minister, Health Secretary, Chief Minister. I met so many politicians for making a national rare disease policy. After some time, from everywhere, I got the same reply that there is no policy for these diseases. So I became very nervous. I thought that I will not sit and I will not watch my child dying every day. I filed a suit in High Court under Right to Life, Article 21. After some time, there are some other court cases were also there. And slowly, this case gone to the Supreme Court of India. And still this case is under sub judice. And in the meantime, few more high courts passed such favorable orders for rare disease patients. And one national rare disease policy made in between. But the national policy was not effective. And still it is not effective. But we have the national policy, actually. In the meantime, the company Shire became Takeda because Takeda take over the Shire Pharmaceuticals. And they started again a charitable access program and my son was selected for that charitable access program. And now he is receiving treatment from Takeda and he's doing exceptionally well. But I did not sit because I had already decided that I will fight until the last patient of this world will get his drug. So I formed this Rare Diseases India Foundation with other parents of rare diseases. And I thought we have to work together and we have to get the drug for all the children in the country. So still we have one policy in the country, but the policy is not appropriate for all the rare disease children, because as far as I am thinking, in this policy, it is already written that the crowdfunding provisions for group 3 children. And in group 3 children, all the MPS kids are coming in these group 3 category. And for this group 3 category, government has asked to do some crowdfunding. I don't think crowdfunding is sufficient for the treatment of any child. Government has also made a platform for crowdfunding, but the funds has collected very less. That is not sufficient even for single child. So I appeal to the government of India, so please make such an effective policy for the country so that all the children can get their treatment. Thank you.
Thank you, Saurav, for kindly sharing your journey, which really has been a difficult one, but not losing hope and fighting through the system and helping other children in the country and on developing the national policy on rare disease. That's really a great amount of work, and it really requires a lot of patience and a lot of courage to go through that. Thank you very much.
Thank you.
Now I invite Ms. Ingrid from Estonia. Hello, Ingrid. Welcome to the program. And Ingrid is a mother of 3 children, one of them who has been diagnosed with MPS 3. And Ingrid is going to share her journey on bringing up her child with MPS 3. Over to you, Ingrid.
Yes, I'm here. So thank you for inviting. I had to say that my English is maybe not so good, but if something is not understandable, so you can ask and I try to explain. So my name is Ingrid. Here is Rahel. This is my daughter who have MPS 3A. It's San Filippo. And so I'm 43 years old. I have 3 kids and 1 grandson. Only Rahel is with MPS 3, but another kid is, they are all right. So they are healthy. We get our diagnosis 4 years ago, because when Rahel was born, she was a totally normal kid, like Saurabh says also. She was totally normal. We didn't notice nothing about her. But when she goes to kindergarten, then their nannies start to speaking that Rahel is a bit slower. She is not doing. She's not like usual kids, so they noticed that something is wrong with her. So I was going immediately to genetic, and our genetic was very big experience. And when he saw Rahel first time, he say immediately that this is Muco polysaccharidosis, because their faces is a bit different, as we know. So after this, when we got diagnosed, everything is changed. Nothing is the same anymore. What can I say? So now it's past 4 years. Now it's past 4 years. So basically, I have 1 6-month-old kid who is walking. So she's behaving like a small baby. I have to feed her. I have to change her diapers. Everywhere where I go, I have to take her with me. So basically, I stuck in her home with her. So, but it's okay for me because I never know for how long time she exists. So I try to give my best that she is happy until the end of her life. And what is good? I'm sorry, I forgot to tell that I'm from Estonia, and we have very small country. We have only 1.3 million people. Not only one city. All countries 1.3 million. So as I know, here we have only 10, 12 kids with mucopolysaccharidosis. So Rahel is one, and Rahel is different because we got one. We was going also in Paris, in France, to what she have received experimental treatment. So the company who was doing this to her, it was Lysosomes. Maybe you hear about this, but unfortunately, it doesn't help us. So now her son Filippo, her MPS is destroy her anyway. So, but we try, we give our best. And I want to speak about health care system in Estonia because I think it's very good here. So as I have a special need kid at home, and our local government in Estonia, it's helping us a lot. So for example, I can go to work because from government, I have support person who is coming every time when I need. She's coming here and she take care of Rahel. So everything what I need, diapers, I don't know, strollers, what else? Everything is basically for free. So maybe I pay 20 euro maximum per month. So, and I have everything what I need for her. What I mean, so, and they pay, of course, money every month because around 240 euro that if I need something, so I have to buy diapers, I have to buy stroller, I have to, so this is a different story. So, but I'm, this is my opinion, it's very good healthcare system here. What I want to say about more to being parent of MPS kids. So, so as I told, I'm stuck with her at home. So, and all your friends, of course, turn your back on you because because if you have a kid with MPS, it's not you are not a comfortable friend. Because always where you are going, you take your kid with you. And it's not possible to just sit down and relax. As you see now, she's walking. She wants something. She wants attention, and so basically I'm 24/7 with Rahel if I'm not at work, because and for me it's more comfortable to stay at home because I adapted all my home for Rahel. Because she's only walking, she's break something, she wants something. She's always doing the mess. And what is one bad thing? So I have a 10 years old son, but all my attention goes to Rahel. So this is also one thing what is not very good with to being parent for San Filippo kid or MPS kid, because another kids, sisters, brothers, they are suffering because of that, because all attention goes to MPS kid. So I think I don't know, maybe you have some questions about something. So I don't know. No one have question.
Thank you, Ingrid. It was really lovely for you to share your experiences. So, does your child speak? Does she say anything yet?
That's she what?
Does she speak anything yet?
No. This I forgot to tell because she was totally normal kid until 3 years old. So we got diagnosed when she was exactly 3 years. Then she was okay. But after, I think 6 months later, she started losing skills. So for now, it's 4 years after we got diagnosed, she is not speaking anymore. She don't have emotions. So if before she was a very funny girl, she was making like jokes. She was speaking, she was making jokes, she was singing a lot, and now she losing her speech 2 years ago, totally, like she don't speak nothing anymore. Sometimes she's making some noise like baby, like blah 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 or something.
Okay.
And no emotions. What? Sorry?
Okay. And are you treating her with any medications for hyperactivity or anything? Nothing?
No, she don't have this kind of hyperactivity, like she's aggressive or something. She just walking like me. No, I didn't notice with. So San Filippo or MPS 3, it's like Alzheimer, childhood Alzheimer.
Right.
So, and she's just walking around. Like you saw before, she's coming to me, she's going away, she's coming to me, she's going. So all day she's walking because even if her legs is not so good anymore, but she's walking. So she don't have hyperactivity.
Okay.
And she's sleeping well now in the night. So sometimes I give her melatonin only, because it happened, I don't know, maybe 3 times per year when she don't sleep at all night.
It was really lovely listening to you. It was really lovely and inspiring, I'm sure, for everyone who's listening. Thank you so much for sharing your experience, Ingrid.
Thank you too also.
Dr. Shweta, do you want to take it?
Yes. Thank you, Ingrid, and thank you, Veronica, for the questions. Ingrid, your story is also very inspiring, and it really requires a lot of strength to be a mother to MPS 3 child. Thank you for being strong and inspiring other parents and sharing your story with us.
Thank you.
Now I invite Akash, Mr. Akash Prasad, who is 20 years old, and he himself is diagnosed with MPS 1. And Akash is aspiring to be a good lawyer in the future. He's currently pursuing a degree in LLB and business administration in Jharkhand. Welcome, Akash. And
thank you, ma'am. Ma'am.
Yes, you can speak, Akash. आप बोल सकते हो आकाश, मैं translate कर दूंगी.
Okay, ma'am. Ma'am, my name is Akash Prasad. My father's name is Jagdish Prasad. My mother's name is Jagdish Prasad. I'm living in India, Jharkhand. And मैम मुझे MPS 1 का बहुत प्रॉब्लम है मैम, और मुझे दवाई लग रही है अभी. तो मैम
हाँ
यस मैम. मैम मैं तो यस मैम, मैं नॉर्मल ही हुआ था. मम्मी जैसे बताती है, मैं नॉर्मल जैसे चाइल्ड होता है उसी तरह का मैं हुआ था. 4 kg का मैं हुआ था. तो जब मैं 2.5 साल था तब मेरा एक ऑपरेशन हुआ था मैम, हार्निया अपेंडिक्स का. ऑपरेशन के बाद मेरे में कुछ सिम्टम दिखा, हल्का हाथ में स्टीफनेस आया और हाथ थोड़ा हल्का कड़ा हो जाता था, मतलब स्टीफ हो जाता था, टाइट हो जाता था बहुत ज्यादा, और ब्रश करने में प्रॉब्लम होता था, और कलाई के जो नसें हैं, वेन्स है, वहां पे पेन होता था मुझे. तो इसी को देखते हुए धीरे धीरे मेरे ट्रीटमेंट नॉर्मली जो होता पीडियाट्रिक्स के पास शुरू किया गया। तो नॉर्मली रांची में डॉक्टर देखे तो डॉक्टर क्या है नहीं है वो ये एक्सप्लेन नहीं कर पा रहे थे कि एक्चुअली क्या हुआ है। उसके बाद जब मेरे पापा का जॉब लगा था तो उसमें मैंने भी अपनी कंपनी में दिखवाया, गांधीनगर हॉस्पिटल में मैंने दिखवाया और वहाँ पे मेरा ट्रीटमेंट स्टार्ट हुआ। वहाँ पे ट्रीटमेंट स्टार्ट हुआ तो वहाँ पे मैम मुझे वेलोर 2007 में मुझे रेफर किया गया था। मैम ने वहाँ मुझे रेफर किया वेलोर में 2007-8 में। तो वहाँ पे डायग्नोसिस हुआ तो मैम वहाँ पे पता चला कि MPS 1 है। वहाँ डायग्नोसिस हुआ और 2010 में मेरा एक ऑपरेशन हुआ था मैम हिप बोन के पास, जॉइंट के पास, हिप बोन जॉइंट है वहाँ पे। तो मैम जॉइंट के पास ऑपरेशन हुआ था तो वहीं पे मेरा ट्रीटमेंट हुआ और वहाँ पे पता चला कि MPS 1 है और इसका जो मेडिसिन है बहुत महंगा है, अफोर्डेबल नहीं है मिडिल क्लास फैमिली के लिए, ये अफोर्डेबल नहीं है। तो मेरी कंपनी के पास हमने गए, वहाँ पे अप्लाई किए कि मेडिसिन की हमें जरूरत है। तो कंपनी ने बताया एम्स जाने की। एम्स बोला तो हमने एम्स आए, न्यू दिल्ली एम्स में। तो वहाँ पे डॉक्टर मधुलिका काबरा मैम ने मेरी चेकअप करती हैं वो, और उन्होंने बताया कि MPS 1 है और एल्डुराज़ाइम की ये दवा लगेगी। तो वहाँ से हमने फिर अपना जो प्रोसेस था मेडिसिन लेने का वो हमने फिर अपना शुरू किया मैं। और मेडिसिन लेने में तो थोड़ा परेशानी वगैरह हमारे साथ आई बहुत सारी, मतलब बहुत परेशानी हुआ, कंपनी देगी या नहीं देगी, बहुत कॉस्टली है क्या है वो सब। तो कंपनी आज ये मेडिसिन मेरा शुरू कर दी है। तो मेरा ये मेडिसिन 7 इयर्स हो गया मैम कंप्लीट, ये 2022 में 8 इयर्स ये चलेगा मेरा और आगे 8वां साल है मेरा ये मैं दवा लगाते हुए। और मैम ये दवा लगाने के बाद मेरी लाइफ बहुत बेटर है। मतलब पहले मैं मुझे दवा नहीं लगता था और मैं जब ये देखता था कि नॉर्मल पेशेंट से, मतलब नॉर्मल बच्चे हैं वो बहुत कुछ कर ले रहे, मैं नहीं कर पा रहा था, हाइट ग्रोथ नहीं था। मुझे बाइक चलाने का भी बहुत ज्यादा शौक था कि हाँ मुझे बाइक चलाना है, ठीक है, तो बाइक वगैरह ड्राइव नहीं कर पाता था। अब है कि अब बाइक कार वगैरह आज मैं सब कुछ चलाता हूँ। आज मेरी लाइफ बहुत बेहतर है, बहुत ही बेहतर। और आज के समय में ब्राउन जिम डेली मैं जाता हूँ, दवाई लगती है पर वीक, और जिम के साथ अपना हेल्दी डाइट मेंटेन करके रखा हुआ हूँ मैम। और एक्सरसाइजेज वगैरह जो भी है मेरा वो मैं पर डे का रहता है।
Thank you, Akash. So I would brief out what Akash shared in English. So Akash was born in Jharkhand and he was normal at birth, as his mother said. And at around 8 years of age, he had hernia, inguinal hernia, and then he was operated for hernia. And he had difficulty in brushing his teeth because he had pain in his joints. And around 2007, he was diagnosed with MPS 1 in CMC Vellore. And in 2010, he underwent a surgical correction of deformities at the hip joint. And when they went seeking for treatment, they were not able to obtain treatment. And later in Delhi, he approached Dr. Madhulika Kabra, who helped him enroll with Sanofi. And he has been receiving his treatment for last 7 years. His treatment is going to continue for another 8 years. Akash was not able to do many of his day-to-day activities before starting off the treatment, but he says that he feels much better with the ongoing enzyme replacement therapy, and now he can drive car, ride bikes, and he also enjoys going to the gym, and he really feels that the quality of his life has improved significantly. And of course, as we all know, he's a very good student and he is pursuing his bachelor's in legal studies as well as business administration. because he wants to work for betterment of the Rare Disease Society in future. Thank you, Akash.
Oh, thank you, ma'am.
आप बहुत strong हो.
Yes, ma'am.
That you have taken forward yourself and
Yes,
have fought through the society, have overcome the taboo of rare disease, and you're fighting towards it, even after going through so much of suffering. Sometimes even normal people cannot do what you are doing. So God bless you. Thank you, Akash.
Thank you, ma'am.
Anyone has any questions for the speakers?
आकाश, आप लॉयर बनना चाहते हो?
मैम अभी तो मैम मैं अभी तो लॉ कर रहा हूँ, तो बट अभी फिलहाल मैं इसके बाद आईएएस के लिए सोच के चल रहा हूँ, आईएएस और ये जज के लिए जूरिस्प्रूडेंस का मैं ये करना
हाँ, वाओ, बहुत ही अच्छा है। हाँ, that's very nice. और आपके कितने भाई बहन हैं?
मैम मैं सिंगल हूँ, मैं सिंगल, भाई बहन नहीं मेरे को।
अच्छा, ओके ओके। तो अब कोई प्रॉब्लम नहीं होती, एवरीथिंग इज फाइन। आप रेगुलर चेकअप वगैरह भी करवाते हो ना एम्स में?
यस मैम, रेगुलर मैम। मेरा अब बोले तो पहले से मेरा लाइफ अब चेंज हो गया मैम, बहुत अच्छा हो गया, नॉर्मल हो गया मैम मेरा। जैसे 26 फरवरी 2015 को ये पहला डोज लगा था न्यू दिल्ली एम्स में मैम मुझे। उसके बाद से ही मैंने अपना एक्सरसाइज वगैरह जो भी था कंटिन्यूअस किया, और अपने मन सोच लिया था कि अब नॉर्मल होना है तो होना है, जैसे करना है।
और आप बिल्कुल नॉर्मल हो। आप कोई मैसेज देना चाहोगे आप बाकी जो छोटे बच्चे हैं जो ये स्ट्रगल कर रहे हैं?
बिल्कुल मैम, मैं सबको बोलना चाहता हूँ यही कि मेडिसिन मिल रही है तो सही है, ठीक है। मेडिसिन मिले तो एक्सरसाइजेस वगैरह करें, अपना डाइट फॉलो करें और आगे बढ़े, ठीक है। और ऐसा ना समझे कि मुझे कोई बीमारी है, मुझे कुछ हो गया है, ये नहीं सोचना है, और जो भी आगे बढ़ना है, ठीक है। और उसके बाद जिन्हें मेडिसिन नहीं लग रही है वो भी नहीं सोचे कि कुछ हुआ है मुझे, वो सिर्फ अपना एक्सरसाइजेस वगैरह करेंगे, वो बिल्कुल नॉर्मल ही रहेंगे, वैसा कोई इशू नहीं है। बस इतना कि अपने आप को कभी कमजोर नहीं समझे कोई, बस।
थैंक यू आकाश।
Oh, thank you, ma'am.
Thank you, Akash. Actually, I have just got a call from Coimbatore. One parent is asking that, is there any gene therapy is coming for MPS 2 patients? This question is from Dr. Mamta Muranjan. Mamta, ma'am.
Yes. There are several alternatives, and yes, we do expect several products, including gene therapy, not only for MPS 2, but also some other subtypes also.
Okay.
But we have to see how these treatments are brought to India, isn't it? It's a very good thing to have programs like this and patient advocacy groups, because I feel whenever there are clinical trials and other such resources, it's always been members of the support societies who have got in touch with doctors also, and through those means we have been able to, sometimes some of our patients have been able to enroll into multi-centric international clinical trials as one of the avenues to access therapy. Till some time that commercial therapies are available elsewhere in the world and in India.
My question is to Tracy. Tracy, are you there?
I am here.
Yeah. Is there any clinical trial going for MPS 2 in Europe?
In Europe, I do not know. In the United States, there are 2. I could not speak to Europe, so I don't want to say anything incorrect.
Okay. Any other questions, Shweta? Dr. Shweta?
Yes, Saurabh.
Any questions from audience?
No, I do not see any questions actually, Saurabh. But I would like to ask Ingrid, Ingrid, can you hear me?
Yes.
You're on mute. Yeah. Ingrid, is there a rare disease policy in place in Estonia? Like you have a particular government policy for rare disease in Estonia?
I didn't understand. So you think about healthcare system, about health policy, yeah?
Yes.
What do you mean? Can you repeat the question,
like
please?
Particularly for rare disease, is there a policy to help out children, or just that that comes within the normal health insurance plans and whatever the social security plan that you're having in your country?
Yes, it's coming from the normal. It's for everyone. So we have
It's for everyone.
like everywhere, yes, and all country have those kids. So it's normal policy for us. So if you have special need kid at home, the government pay for you money for this. As I told you, in my case, it's 240 euro per month, and for this money, and they give for me everything what I need from diapers until strollers. They give me 90% for 10%. So I have to pay only 10%, and another pay government. And this is normal, and support person is coming also from government. So I have support person every month, 200 hours. So it means that I can go, I still can go to work. So, and this is normal for us. It's nothing special, yes. But with Rahel, I was going to in Lysosomes in experimental treatment. For this, government didn't help us. We find ourselves from Google this possibility. We was going also in Barcelona, but for Barcelona, Rahel wasn't good because of something. The blood wasn't so good as they wish, and but France was ready to make a surgery for Rahel, and but government doesn't help us with this. We was finding ourselves, and Lysosomes pay for everything, for our fly, for our hotels, for being there, for food, for everything. So this is not from government.
Okay.
Mm-hmm.
Thank you so much, Ingrid.
Okay, thank you.
Thank you. So now I invite Mr. Saurav Singh to give us the vote of thanks.
Yeah, thank you so much, all of you, the respected speakers, and all of you for giving your wonderful speech on MPS Awareness Day. Many thanks to our audience who are watching us today and becoming the part of this mission to raise awareness around the world. With all your support and everything, now we feel that we are rare but not alone. One day, the time will definitely come when all the patients will have their treatment very smoothly. Thank you, Dr. Mamta Muranjan, for coming into this webinar. And thank you, Tracy, for taking part in this webinar. And Dr. Veronica, thank you so much for your wonderful PPT. We really enjoyed your PPT, and Dr. Mamta Muranjan's PPT. You were really wonderful and knowledgeable. And thank you, Ingrid, for coming here and sharing your journey. Thank you, Akash, for coming here and sharing your own journey and your struggle. And you are doing really wonderful. We are really impressed with you. And thank you, Dr. Shweta, for moderating this session. Thank you so much. Thank you, everyone.
Thank you, sir. Thank you, ma'am.
Thank you, Saurabh, for a beautifully organized session. Thank you, everyone.
Tracy, Akash, thank you.